my name's Guru. As you guys probably saw, I don't need to go through like the whole part where I talk about all the things I would talk about. I'm going to talk about failure. Basically, this topic came to me because I wanted to talk about something that I guess I became an expert in over the last 4 years. We define failure as a lack of success or someone who demonstrates a lack of success. It presents a unique challenge for residents because getting into residency means you're usually successful. It requires a significant amount of effort getting through college, medical school, and then applying and then successfully entering a well-respected emergency medicine residency. None of us usually define ourselves as failures, but many of us fear failure, some more than others. So today I just wanted to talk about why we should fear it less and instead use it to empower ourselves to continue down our paths of success. So the objectives for the talk, we're going to go through why we fear failure, reframing how we approach failure, and how we can learn through failure. So like everything else, we're going to start with a case. You're sitting in CCT a few days after Christmas and the red phone rings. You hear, this is EMS with a notification. We have a 24-year-old male, cardiac arrest, no vitals, ETA 5 minutes. 24? Yes, 24. Is it a traumatic arrest? No. You quickly notify the team of what's coming and run to the resus room and gather your supplies. You get your airway cart, your intubation gear, and you turn on the glide scope. You start to mentally prepare for what you're about to see as EMS rolls in. When EMS comes in, they say they were called to the house for a cardiac arrest. The patient's mother says he woke up in the middle of the night and said he couldn't breathe and then collapsed in front of her. When EMS got there, they found him pulseless, started CPR, and intubated him. They were able to get Ross, so they transported him to the ED. You're standing at the head of the bed as they move him to the stretcher, and you start with your ABCs. You check the airway and take out your blade and get past the posterior oropharynx, and sitting in the right above the epiglottis is an inflated balloon at the end of an ET tube. You quickly pull out the tube and let the team know that the patient needs to be re-intubated. You get medications on board and you start bagging him back up. His SATs come up and you go in for your first attempt. You clearly see the cords and grab your tube. You get the tube right down to the cords and it gets stuck and it refuses to pass. You try again, but the SATs start to drop, so you come out and you bag him back up. This time you get ready to go in again, this time with the glide scope. You put the glide scope in and now everyone can see what you see. The cords are perfectly visualized, but as the tube goes down, it gets stuck right above it. The senior grabs the blade from you and puts a bougie right through the cords. She then slams a small ET tube right over and everyone breathes a sigh of relief. This was my patient as a junior, and when I walked out of the room, my hands were still shaking. I looked up at my attending, who was Dr. Smith at the time, who was also my program director, and told her, I treated this patient 3 days ago. This was by far one of the worst cases I had during my time in residency, and it was one of the first times I felt like I was directly responsible for a patient's suffering. The case actually starts a few months earlier. The patient, who we'll call Jason, was a level 1 trauma code in October. He came in after suffering multiple gunshot wounds, was intubated in the ED, and was taken to the OR emergently. In the OR, he was stabilized and admitted to the SICU, where he was found to be paralyzed below T6. He had a complicated SICU course where he suffered a C. diff infection, he had his jaw wired, and he had significant problems with his breathing that required chest PT and Med-Nabs around the clock. One night, as the SICU call resident, I got called by the nurse about a patient refusing morning labs. Jason, due to a C. diff infection, was a room we would pass by on rounds. Only the attending and the resident taking care of him would go in. This was my first time meeting Jason, and when I walked in, I saw someone a little younger than my little brother who was depressed from having no function of his body below his waist. On rounds, he was known for frequently having outbursts, while his mom would sit by his side and try and calm him down. She was equally heartbroken that her once cheerful, active son would never be able to move again. When I walked in that night, I asked him what went wrong. He told me that the nurse kept trying to draw labs from his arm, but when she could easily draw it from his leg where he didn't feel any pain. Obviously, it was policy that the nurses couldn't draw labs from his leg, so every night after that, I would go in and draw labs from one of his foot veins. During the few days I had him as a primary patient, we started to form a relationship. And by the end of the rotation, we were pretty close. The day before Christmas, I was working in the ED when I picked up a patient in 20 right. I walked in and Jason's mom looked at me and said, "Hey, you're the doctor from the ICU." I could not recognize Jason without the IVs and the tubes, but he looked a lot better than what I remembered him. After a few questions and a quick exam, I realized he was having trouble breathing again. He was wheezing, so we gave him a few nebs and some steroids and fluids. He wasn't improving, so we placed him on OBS. A few hours later, I heard a scream come from his room. We ran over and saw Jason stridorous with his sats dropping. He was anxious and scared, and I tried to calm him down. So we cranked up the oxygen, and with slow breathing, his sats started to pick back up. We quickly upgraded him to a full admission and had ENT come by and scope him. Unfortunately, they couldn't find any cause for stridor on exam. He looked a lot better and felt better, and the episode only lasted a few seconds. At the end of the night, I said goodbye to them and told them that they would get a full workup on the floor. Unfortunately, 3 days later, he arrested at home and ended up back in CCT. He was admitted to the ICU, never woke up, and was trached, pegged, and sent to an LTAC. When I saw him that last time, it felt like the world had collapsed. A few months later, his case was presented at M&M. I listened quietly as we dissected the case and went through things that could have been done that may have changed his outcome. It was tough to listen to, but it made me question if the patient would have had a different outcome under someone else's care. The reason I wanted to share this case to start off the lecture is that I hope by sharing a time when I felt like I had failed in residency, I can show you that it's possible to get through it and improve yourself. Part of the reason we resent failure is because of the shame associated with it. For me, it was also an especially vulnerable moment since I experienced it with one of the people who I respected the most, my program director. For a year and a half before that, I had moments of feeling like an imposter, where if I missed a diagnosis or messed up a procedure, I felt like I was about to be discovered as a fraud who had snuck into this emergency medicine program. At that moment, I thought the game was finally up, but this experience taught me that by being able to get through it and not being kicked out of residency and not losing the respect of the people I cared about, I could get past failure. So to start, let's talk about why we fear failure. Failure is often associated with negative emotions, including shame, feeling weak, and it has the potential to bring negative consequences. The first lesson here is that success and failure exist on a spectrum. We have the power to decide if our desire to succeed outweighs our fear of failure. If we do not make ourselves vulnerable by attempting tasks that may result in failure and instead try to hedge our bets to tilt the scales towards success, we miss opportunities to truly expand our potential. We're all guilty of seeing dizziness pop up on the board and looking at the triage note that says history obtained by Syracom and immediately pretending we didn't see that patient pop up. We don't want to expose ourselves to the possibility of failure, which is what we expect when we see a dizzy patient who can't speak English. It's painful to sit there for 30 minutes with a Syracom interpreter only to come back to present to your attending a limited history and the broadest differential that requires both an MRI, a CTA chest, abdomen, pelvis, and numerous labs. By avoiding it completely, we don't make the next time we have to see that patient any easier, and we eventually have to see that patient. If you are not vulnerable and try to avoid experiencing failure, you also avoid experiencing the pinnacle of success, such as when your HINTS exam points to a central etiology and you successfully catch that elusive posterior stroke. The beauty of our specialty is that we truly have to be prepared for anything at any time, And this means that no matter how much you try to play to your strengths, your weaknesses will always be exposed. Part of the fear of vulnerability is also comes from wanting to belong. When we start intern year, we're hardwired to want to fit in. We're clinical monsters, so we don't make mistakes. We see 30 patients a shift, and we can do any procedure with one hand behind our back. We try to fit this image that we see portrayed by our seniors and our attendings, which can often leave many of us feeling like imposters. This leads to what many of us know as the imposter syndrome. Imposter syndrome is a psychological term that refers to a pattern of behavior where people, even those with adequate external evidence of success, doubt their abilities and have a persistent fear of being exposed as a fraud. This tends to be more prevalent in women and minorities, but it's also something that almost everyone experiences. Imposter syndrome is thought to derive from individuals not seeing themselves reflected in people in positions above them or their colleagues. This is especially true for women and minorities who lack role models and mentors, and this leads to a greater sense of feeling like you do not belong. This may be why many of us feel like imposters when we fail, since we rarely discuss our failures openly or see the many failures that those that came before us experienced to get to their current level of success. This is also a cultural problem in medicine itself. We have difficulty addressing our failures. We publish millions of positive trials, but hide the negative trials, as we did with TPA research. We discuss our saves and celebrate the individuals openly, but we anonymize our M&Ms to protect those involved. We tend to sandwich our feedback to hide the one negative in a string of positives. But in the end, by hiding our failures, we prevent open discussion that reduces the stigma and negative emotions we often attribute to the experience. Therefore, when we fail, we feel like we do not belong in the field or specialty where we literally have never heard of others failing or see it in a secret, anonymous fashion. Studies show that the imposter syndrome, while possibly helping to drive one to succeed, is also associated with many negative consequences, including emotional exhaustion and increased work-family conflict. It has also been connected with burnout and suicide, which is a major issue in our specialty. Looking at the data, a scoping review found that between 1/3 and slightly less than 1/2 of residents experience imposter syndrome during their training. It found factors such as female gender, low self-esteem, institutional culture, and perfectionism tend to lead to higher rates of imposter syndrome. Our culture is especially problematic since asking for help or not knowing the answers is often viewed as a sign of weakness within medicine. On the other hand, things like social support, validation of success, and positive affirmation tend to lower rates of imposter syndrome. In addition, using personal reflections and sharing common experiences helps normalize the feelings of imposter syndrome. Part of feeling like an imposter is the belief that those who are faster, smarter, and more capable were always perfect. They never failed or had to study hard to get there. They showed up intern year with the perfect understanding of renal physiology and could place a central line without an ultrasound. However, if you dive deep and speak to many senior residents or attendings, they discuss their battle scars. They have stories where they felt less than or imperfect that challenge their identity, which is what residency does. You go from being the hotshot fourth year med student who knew people on every service you rotated with, to the intern who tries to quote Tintinallis and gets schooled on it based on recent EBM. This leads to my second point about the mindset you bring to residency and how it affects your approach to failure. I know Delna discussed this a little bit, so I'll kind of skim through it. We all kind of experienced this at some point in our life. We had teachers who knew who the smart students were and who the students who struggled were. We were never rewarded for the effort you put forward, only the result. At the end of the day, we don't rank applicants based on the number of UWorld questions they do. We rank them based on their step scores. Well, I don't want to start that argument. I do want to discuss fixed and growth mindsets. So Carol Dweck coined this concept and wrote about it in her book, Mindsets. Basically, she characterized two groups of learners and found that their mindset influenced how they responded to challenges and how that affected their ability to learn. The basic premise was that those with fixed mindsets believe they're endowed with a certain amount of intelligence and talent, while those with growth mindsets believe they all start at a certain level, but have the potential to expand through their effort. I don't know if this is going to work. No. Well, so this was this is a classic example of failure. But I was basically going to show Trevor failing to take a shot and then successfully taking one 6 months later as how we can improve our talents. In the end, the mindset we bring to residency is a key to our growth and our eventual success. Our mindset allows us to use our energy on learning instead of just trying to look smart. Those of us that were trained in a fixed mindset may fear we lack intelligence or the talent to truly be successful. This may lead us to back away in the face of adversity or when offered new challenges. By having to put forward effort, we see ourselves as less than those who seem to naturally complete the task. This is especially applicable in the ED with relation to speed. Those with a fixed mindset tend to respond to failure by cheating, finding someone who did worse, or avoiding the experience altogether. In the ED, when we see patients, when we have a tough shift and we only see 6 patients in 12 hours, those with a fixed mindset may point to the rotator who only saw 4 patients or try to make up for it by cherry picking patients in order to boost their numbers. These behaviors prevent growth and inhibit learning. On the other hand, employing a growth mindset requires us to stop over pursuing goals, which tends to only promote cheating and often inhibits performance. A good example of this was an article sent by Dr. Stetz about swimming. In the article, the swimmers just wanted to be fast, but their coach explained to them that speed was a byproduct of good technique. We often chase after a target, such as the number of patients we see in an hour, instead of focusing on what truly matters, which is our technique. In comparison, those with a growth mindset may respond to this challenge by asking how they could have gotten a history faster, or wonder if they truly needed to CT that patient. By analyzing their mistakes, they're able to refine their skills and get faster on their own. Like the swimmers, our speed is a byproduct of good technique. So now that we've covered why vulnerability and imposter syndrome make us fear failure and how we can change our mindset to approach failure differently, we need to develop our ability to learn through failure. My final point is that in order to help each other grow, we have to create a culture that allows individuals to cope with uncertainty and embrace failure. Visualizing mistakes allows you to prepare for them. A controversial topic in simulation is simulating unexpected patient deaths. Imagine going to a sim session where you're asked to lead a resuscitation. You try everything, but despite your best efforts, the patient expires. Sim sessions are supposed to avoid this in order to protect learners from the psychological stress that impairs their ability to retain information. However, there's an argument for using these sessions to expose learners to stressful environments, followed by a thorough debrief, so that they can process emotions and related to losing a patient or making a mistake. A French study compared unexpected death simulation and showed that the scores in medical students and showed that anxiety scores before and after the experience were similar amongst the two groups. Subsequently, they followed those students 3 months later on the wards and found that the students who were exposed to an unexpected death simulation had lower anxiety levels compared to the students that did not. While the data is still controversial, this option has the potential to help us cope with failure and process those emotions in a safe way. When we pursue a goal, we don't know if we'll succeed or fail. Every airway, central line, or chest pain patient could result in a missed tube, an arterial cannulation, or a missed dissection. We have to learn to be more comfortable with that uncertainty and the possibility of failure. We often envision success and focus on the positive outcomes, but there may be value in focusing on the negative ones. This concept is derived from the practices of Stoic philosophers and was put forward by a psychologist named Albert Ellis. He believed that the best way to tackle uncertainty was to focus on the worst case scenario instead of the best case. We tend to do this to some extent in our daily practice when we see a chest pain patient and think about our differential in terms of worst first. We also do this when we prepare for an intubation, when we consider what tools we can use if we fail to intubate the patient. Applying this concept more broadly and regularly with even simple tasks may allow us to tolerate a greater level of uncertainty. For example, what is the worst thing that could happen if you present a patient to an attending that's going to give you a hard time about it? Or how much time will you truly waste by going to L&D for a full 2 weeks? Learning occurs when we least expect it, when our preconceived notions are challenged and what we thought would happen doesn't. In order to keep on learning, we have to open ourselves to uncertain opportunities. Lastly, going back to growth mindsets, studies show that a child's mindset is influenced by their parents' views on failures. In the realm of residency, our parents are senior residents and our attendings. When I walked out of that resuscitation room, Dr. Smith could have done what I thought she was going to do and thrown me out of residency, but instead she built me back up. Additionally, after the M&M, I sat down and ran through the case with Eden, who helped talk me through it and pointed out where I could learn from my mistakes. Together, they taught me that being vulnerable and open to teaching could help me change how I practiced and help me get over the fear of suffering another setback in residency. This reflects the need for a supportive culture that doesn't penalize failure and instead uses it to launch future growth. In summary, this case was really tough, but it taught me a great deal. It taught me that I had mentors that could see me fail and build me back up. It allowed me to be vulnerable, to push myself harder and try to take on bigger challenges. And it taught me that despite making a mistake, I could learn and grow from it and that it didn't define me. Lastly, I know that when it felt like what it felt like to fail and could cognitively cope with it when future mistakes happen. Our fear of failure comes from trying to avoid being vulnerable and trying to fit in. By sharing our stories, we can reduce stigma and create a supportive culture. We need to recognize that we should approach failure with a growth mindset that values the effort of overcoming failures rather than focusing on avoiding failure. Embracing failure as a path towards success requires colleagues who allow us to be vulnerable as we face failure. With the right support, the right mindset, and a reasonable tolerance for uncertainty, we can conquer the many obstacles of residency and eventually graduate as successful clinical monsters. And finally, just a thank you to all the PGY4s and the rest of the residency, as well as my amazing family who's been there and supported me through the last 4 years. And then to all the PTs and faculty who have stood by, watched me fail many times and built me back up. And then lastly, thank you to my co-chiefs who have been amazing, and I would not have been able to get through this year without you guys. And good luck to the clowns that have to take this on next year.